Okay, let's make a start. So today, thanks for all of, let's put it this way, thanks to all of you who have joined today. My name is Raman Singh, and obviously I'm going to be starting a new unit today, which is social and community welfare provision, as you can see on your slide and the screen that I've shared. We're going to start off with this new unit, which has 3 learning outcomes. But what we're going to do today first is look at a bit of an overview in terms of what is social and community welfare provision. Then we'll go into discussing learning outcome 1. And then in between the discussion of the learning outcome 1, what I will try and also do is basically relate this topic to things like why is Britain a social and welfare state, and obviously share with you some handouts which are up on Moodle that you would be able to read, and go through for some additional knowledge and, further reading. So feel free to ask me questions when you have any, and either they can be asked through the chat route or, through unmuting your microphone, and let's have an interactive discussion and a session. So let's start off with this particular unit, and what I want to do is just briefly show you the unit spec for this particular unit, which essentially will allow us to place this into a bit of a context. So let me just share the unit spec. So when you look at this particular document, which is the assignment brief, as well as giving us the assessment grid on this that we need to know, this particular unit is going to be graded. That's the first thing that you need to note. And obviously, you could achieve pass, merit, and distinction. The assignment is going to be up to a word count of 3,500 words, and it has 2 parts to it. One part being 2,500 word essay, and the other being a table or a poster that you would need to design, which will cover the basic components of the origins and development of social care development in the UK in particular. Now, this is a 6-credit unit. It's one of the specialist units in healthcare studies that you would need to, that you're going through. And this particular unit has 3 learning outcomes. In the first learning outcome, what we are going to be looking at primarily is, discussing things which are related to what are factors which affect healthcare. So here we are going to go into something called social determinants of health, and these social determinants of health would be the factors that typically affect the delivery of health and social care. So in general, we'll be looking at understanding how these social determinants of healthcare and what are the main factors which essentially influence the delivery and availability of healthcare services within a particular economy or within a particular geography. And these factors would typically include 3 different factors that we will go into detail, and they would be general socio-economic factors. We'll be looking at cultural and environmental conditions which affect how people receive health and social care, what conditions dictate let's say their conditions in terms of health and social care. We'll also be then looking at social and community networks, and we'll be looking at individual lifestyle factors. For example, you choose to eat oily diet, or you choose to have an exercise routine, or sometimes we say we eat 5 of the 5 of veg, 5 of fruit and 5 of veg a day. And these are individual life factors which can also affect the way your health turns out, or the way your health and hygiene can have an effect on how you in general as a person fare with these let's say services. So when we look at personal factors, it could include things like age. So say, for example, if you're young, if you're in the middle age, you're in the old age, how would these factors determine your healthcare condition in particular? You would look at, for example, some of the other factors, which could be income, when we talk about demographics, your education, and living conditions where you live. So we'll go into a bit of detail in that, but that's what the first learning outcome would cover, with 2 assessment criteria, talking about key social issues and contemporary issues in this society, which basically help determine what kind of healthcare facilities you have access to, and how you turn out, or what kind of let's say welfare you get as an individual within the state. And the second one would be to look at, discuss how these issues affect your health and well-being. So if you come from a deprived background, as they sometimes say, or if you come from a background wherein some of these facilities or area in these facilities is not available, that people coming from those areas or basically background, when we talk about developed countries, underdeveloped countries, developing countries, we know that the state of conditions in terms of health and welfare, hospitals, surgeries, doctors, nurses, is not that developed. So in those cases, we see life expectancy to be less, diseases or treatment for those diseases or chronic illnesses is not there, and that leads to loss of life. So what we see is life expectancy is lower as compared to developed countries or highly developed countries. So those are the factors that we will go into briefly discussing in learning outcome 1. In learning outcome 2, we are going to be focused on understanding how the provision of health and social care services can be delivered effectively to members of public or in a particular geographic area with the involvement of community. And that is where we will study what is social and community welfare provision. So sometimes, for example, a broad example that I will give you here is, assuming you or somebody that you know has met with an accident, and that would have led to some sort of a surgery. After the surgery, the person is trying to recover. They then are released or discharged from the hospital. They come into their home, and then social workers would come in and obviously provide some of the surgery, post-surgery support, which could be things like physiotherapy, helping do the normal chores for the person if the person stays without a family. And in those cases, the community and welfare provision side of things starts to play in with the help of local authorities, council, and the social and community welfare setup, which basically tends to provide these services through social workers or healthcare visitors who normally visit the person's home. And in those cases, we would be looking at studying the learning outcome 2. Again, it has two assessment criteria. We're going to be looking at the key milestone of how the provision for this has developed within the UK. And we will look at a particular table, which will give us a bit of a timeline to understand when the NHS started in 51 and was established as the National Health Service, how some of these things over the years with various reports, and white papers which have been published have then brought it into the scope of the NHS Constitution. We'll also be looking at comparing and contrasting these provision of services when they were not there to when they are here and they are available to the members of public, and how this has made a difference in terms of some of the basic services which people receive, and how it has helped in removing, let's say, or addressing healthcare inequalities that we generally got to see in the society before they were introduced into the National Health Service. The third learning outcome is going to be focused on, values and how the values around health and social care provision, or the NHS values in particular, how they have firmed up and how some of these values inform the values that we need to adhere to as health and social care professionals when we deliver these services to, patients, members of public, or, to citizens within a particular country. And when you work within a setup, what we are going to be looking at is the core values that underpin, which are things like 6 C's of healthcare. We look at person-centered values. We look at the NHS values. We are going to be looking at these as core values that underpin how social and healthcare service delivery tends to happen within the National Health Service, and how this is delivered by you and me. How do we interpret this? How do we understand this? And how you and me then deliver these by keeping in mind and putting into practice these core values while delivering the services to, patients. And the second part would be to look at identify and discussing the ethics that underpin how social and healthcare services delivery needs to be, looked at, or how it is going to be measured. So these are the three assessment, learning outcomes that we will be looking at, and some of the assessment criteria in our discussions over the next, 4 weeks. So we're going to be looking at discussing learning outcome 1 today in a bit more detail after a bit of unit introduction. And then tomorrow, we are going to be doing learning outcome 2. And then the following weekend, we'll be looking at learning outcome 3, followed with a discussion on the assignment brief. So in general, let's look at understanding what is first social and community welfare provision. That is what we want to look at. Let's, overall, as an overarching, let's say, topic or, thing that we're going to study in terms of the unit that we're going to study. So let's look at this broadly first. Now, in order to understand, and let's look at this from a key terminology point of view. That means these are key terms that we're going to use time and again when we are studying this particular unit. So what is social provision? What is community provision? those are bits that we have to look at in terms of, health and social care. So when I talk about, social provisioning, what does that mean? So when we in general talk about the key terms which are going to make up this particular unit, social and community welfare provision is something that we need to understand in a bit more detail. So when I say social provisioning, what does this mean? So when I talk about social provisioning, what I mean by that is a vast set of activities, which are going to be both related to, say services which the state will provide, or in some cases, what we are going to be looking at, the essential distribution of some of the goods and services which are required to provide the welfare services to the citizens of a particular country would be termed as social provisioning. So when we talk about social provisioning from a government perspective, or when we talk about social provisioning from a, let's look at an example. Look at when you look at provisioning for food and ration within your home or your own home, and you look at, say, for example, weekly shop, and you do that. What you're essentially doing is you're preparing for the week. So what you're doing is you're provisioning for food, grocery, and some of the other items which are required, that you feel that would be required with the family and family members within this week. And that is what is provisioning. So similarly, when we talk about provisioning from a social perspective or social context, what we are looking at is how are we going to, basically in this case, we are going to be referring to societies and communities that will ensure distribution and availability of essential goods and services which are required to meet the requirement of healthcare provision in a particular geography. So things like hospitals, surgeries, pharmacies, you look at ambulances and emergency services. These are provisionings which the NHS needs to have to be able to deliver some of these services to members of public. So when we talk about social provisioning, we are looking at basically talking about the availability of these resources, which will be provided by the government, by the NHS, and they would consist of essential goods and services that are required to essentially meet the requirements of individuals, members of public, patients who are requiring care as far as healthcare is concerned. Now, when we talk about, say, for example, welfare, in terms of, if I now add, say, for example, the word welfare. So if I look at welfare provisioning, what that would essentially, when I say what is, say, if a question comes to my mind that what is welfare provisioning, now I understood social, but what is welfare provisioning? So when we talk about welfare provisioning, what we are looking at is that in this case, we are looking at the various policies, programs, initiatives which the government is going to be able to take and set into motion that will support the well-being and the delivery of social care services to individuals, members, families within the UK or within a particular geography. So I'll repeat that. When we talk about welfare provisioning, what we're going to be looking at is referring to various policies, programs, and initiatives which could be government-led and some of the non-government institution-led. So, for example, research which is carried out by National Institute of Health and Social Care Excellence. We look at the King's Fund. We look at PHE, which is Public Health England. These non-government or semi-government bodies, along with the government, when they look at various policies, procedures, and initiatives that support and help in the delivery of welfare services to the individuals within a particular geography, would constitute what is called welfare provisioning. Is that okay? Now, this would mean services and benefits which are aimed at ensuring that these healthcare services, for example, everybody needed to get the COVID jab. Now, one of the things which the government would look at from a policy initiative would be that they created a plan, and that plan essentially meant that we'll start with the most vulnerable. So it started with the people who are senior citizens in the 80s, then 70s, then 60s, then 50s, then 30s, and then 20s, and then children. This provisioning that they did this policy creation to ensure that we'll start with the most vulnerable, people who have underlying health conditions, and then we will go down to the fitter or the more younger youth population, to ensure that everyone within the society has had a COVID jab. And that was policy-related decision. But the provisioning of it, that means purchase of vaccines, ensuring that adequate number of vaccines were available, and these were thoroughly tested. There were different government agencies and bodies which were involved, and they ensured, and once MHRA actually approved the Pfizer Moderna vaccine or the AstraZeneca vaccine, then this particular mass vaccination process actually started. And that was provisioning from a social perspective. That means the government procured, ensured that PPE, the various equipment, things which were required for the COVID jabs to be given or administered were all available to be able to give to the members of public. Now, when we talk about welfare provisioning, we also look at what are the various welfare related provisions which the government has created within the UK to allow members of public to get services in equality. That means there is no differentiation whether I come from an A background or income background, or have this education or that education, or where I'm born and bred here, or I've emigrated from abroad and I've come to settle in the UK. There is no such differentiation which the government makes. And in such cases, the system which the government has been able to create to deliver the social and community welfare services is called the welfare system. And this social welfare system in the UK means that UK is a welfare state. That means most services which are provided, which are, let's put it this way, which are default services which people need to be able to get from the government are defined under this particular provision. And that is where it is called social welfare. And why UK is a social welfare state, we will look at that as well. So things like education, you look at healthcare, we talk about, for example, universal tax credit. We talk about, so basically certain areas which are related to, in which the government would provide equal services or services in without any differentiation or discrimination to all members of the public, citizens of the country, would be services which are coming under healthcare, services which basically include education, universal tax credit, and say, for example, housing. Now, these are things which will make and be considered as what is called welfare provision, because the government is committed to ensuring that people are able to eat, have a shelter over their head, and are able to get the basic essential medical services free of cost without having to pay for it. And that is why Britain is called a welfare state. So when we talk about welfare, this is what we mean by welfare, is that these services are available irrespective of where you come from, what your background is, caste, background, creed, culture, whatever it is, where you come from, you will still get these services as these are services provided by the state or by the government in the UK. So to put it into context, what we need to be able to understand is, what do we mean by social provision and what do we mean by welfare provision? Now, when these services are given or are administered to the members of the public, there are various routes through which these services are provided. So these services can be provided through various setups, and they can also be provided through the members of public or within the community. And when we talk about these provisions in terms of how these services are delivered, then we refer to them as a collective term, which is called social and welfare community provision. And this would then cumulatively refer to program, policies, services which are implemented by government and semi-government or other organizations, which will be looking at enhancing the well-being of individuals and communities within a society. Now, this would encompass a wide range of activities, and these activities which the government and the government-related or non-governmental organizations would be providing would be aimed at actually addressing what is called a wide range of activities which will cover social needs, promoting equality, ensuring that overall life of the individual in terms of quality of life of its citizens and the individuals within the country is improved by providing these services. And in the context of UK, when we talk about, this is a very important part because this helps in shaping the public policy that ensures that anybody within anywhere within the UK population it gets and receives the support. So whether you live in Shetlands, whether you live in Scotland, England, or Wales, or you live in one of the British overseas territories, you are going to get the same provision of these services, which are going to be provided by the government and government-related agencies, communities, and that would help you in overall promoting your well-being. That means it will encompass a wide range of activities. Like in the case of COVID, the country was faced with a pandemic. This was not an epidemic just in the UK, it was a pandemic across the globe. But the government took initiatives to ensure, and when I say initiative, that means wide range of activities which were undertaken. Lockdowns, for example, Eat Out to help out, various schemes introduced by the Treasury, the NHS working to introduce, things like making mandatory use of PPE as an equipment, purchasing more of it, ensuring that enough oxygenators and, equipment was available, or provisioning of the three new hospitals which were created in London, Birmingham, and Manchester in order to look at the increased demand of hospitalizations wherein patients needed oxygenators essentially because if people were suffering with COVID, it led to pneumonia and obviously water in the lungs, and that created problems of breathing difficulty. So these provisionings which were done in order to ensure that that we are as a country, as a government initiative and set of activities are able to overcome this pandemic were the set of activities which are undertaken at different departments at different levels, and from a policy, from a planning, from a list of activities perspective, all these were done to ensure that minimization in the number of fatalities or deaths would have been, the aim was to minimize the fatalities and death which were occurring as a result of the COVID pandemic, and the government, say for example, as the pandemic progressed, the government also introduced lockdowns in order to stop the spread of the virus, and these were all initiatives done to promote social and community welfare provision. That means to ensure virus does not spread, people do not get infected, number of deaths could go down, and the peaking in which was happening because of people getting infected with the virus, the government wanted to stop that, and that then at a later stage when the vaccination was introduced allowed the whole pandemic to come under some sort of a control. So these are bits that we will understand when we talk about studying this particular unit, which is social and welfare community provision. So is that okay? Is that understood as a bit of an overarching, introduction to the unit? Is that clear? Any questions on this? Okay. So before we go forward, let's look at a particular video which I want to show, and that talks about why social and community welfare provision actually matters within the NHS, and how this has come into some sort of a shape, and this has been introduced as a policy. So let me share this particular video, which is a short video that we want to watch. So let's look at this particular video for a second.
Public Health England has just launched the latest edition of Health Matters, which focuses on community-centred approaches for health and well-being. Many of the factors that create good health exist at community level. Community life, social connections, and having a voice in local decisions help protect our health and buffer against disease. Communities, which can be either place-based, such as neighbourhoods, or communities where people share a common identity, interest, or affinity, are vital to health and well-being and to reducing health inequalities. As well as having health needs, all communities have health assets that can contribute to the positive health and well-being of its members. These assets can include friendships and networks, local groups, and community and voluntary associations. These assets also include the physical, environmental, and economic resources of a community. These community strengths can help build more positive local solutions for better health. There's a growing interest in the UK in community-centred approaches that can identify and mobilise local assets, promote equity and increase people's control over their health and lives. Community-centred approaches offer a different way to use local resources, and some studies have demonstrated that there is a good social return on investment. This way of working is important for all public health priorities. Community-centred means more than being community-based. Practice involves using non-clinical methods, for instance, using participatory approaches such as community members actively involved in design, delivery and evaluation, especially those members most at risk of poor health. It includes people taking greater control over the conditions that drive poor health, such as their local environment. Our family of community-centred approaches represents some of the practical and evidence-based options that can be used to improve community health and well-being. The four main strands include strengthening community action on health and the social determinants of health, volunteer and peer roles, collaborations and partnerships between communities and services, and increasing people's access to community resources. Localities are encouraged to develop a whole system approach to empowering communities by working across partnerships and sectors to maximise impact and remove system barriers. These approaches should involve members of the community in setting priorities, monitoring and evaluating services and initiatives, and also in mapping and mobilising local assets. Localities are encouraged to commission across the four strands of the family of community-centred approaches as part of action to reduce health inequalities. Local authorities are well placed to measure the health and social outcomes that people say matter, such as wellness, social connections and improved neighbourhood environment. Finally, localities are encouraged to integrate community-centred, asset-based approaches as part of place-based commissioning and strategic planning. Devolution is an opportunity to increase power and control of local communities. This edition of Health Matters highlights some of the successful interventions within the family model that have been implemented across England and could be replicated across the country. So please take a look at the Health Matters online resource. It includes case studies, blogs, video discussions and downloadable infographics and slides that you can use in presentations and in discussions with colleagues. Thank you for watching.
So this particular video, when you look at it, highlights three important facts. So when we talk about community provision in general and services, these are services which are provided from within the community to the members of the community and do not involve any medical procedures or essentially, any sort of, let's say, I would say medical procedures or, any sort of medical operations or procedures which are required to be performed. Now, when we talk about the importance of community health services and its provisioning to be able to provide wider support to people being able to do their, let's say, daily chores and obviously maintain themselves, as far as possible. That means they are able to independently carry out their own functions at their own, and in their home is the context of what community welfare provision comes into. So when we talk about community health services, let's put this into context. There's a whole set of community provision services, or services which are classified as community health services can be, mentioned. But what I've done is on this slide, basically looked at just mentioning a few that we can relate to. So these services cover a wide range of services which allow individuals to get support from the wider framework or the network within the National Health Service from birth to end of life. So, for example, when somebody, if you have, let's put it this way, say, for example, if your missus or your partner is having, a delivery or she's giving birth, then in those cases, what will happen is you would generally see that after the birth has happened and, the child is born or the baby is born, after you've discharged from the hospital, there is a certain set of services which are then delivered by the triad set of nurses when they come and visit you at the home to check on the welfare of the baby and the mother and see how the mother is recovering from the, from, for example, the, let's put it this way. If you've had a natural delivery or if you've had a C-section, then obviously in such cases, the nurses and the social care workers which will come and visit you at home would be basically looking at ensuring that the mother and the baby are recovering well and they are, getting, there are no signs of any, let's say, I would put it this way, there are no signs of any concerns. And this would be the care which the community nursing or the community would, so for example, welfare side of things related to social workers and nurses, which would be providing to you at your home. So in this case, when the community health team plays a role in supporting your complex health needs, which is the mother and the baby recovering, and obviously, going back to normal, say, for example, things that you normally do, they would be looking at providing you care and the needs that you have by regular visits to your house. And in this case, the visits would be, facilitated by the local council, by a local, surgery team or the hospital where you've given birth, and they would be looking after you to ensure that you are able to get back to your normal set of operations in a certain amount of time or in as quickly as possible. And these services which are delivered through the community route would include, for example, I put a few on the slide. For example, district nursing, you look at child care, child healthcare services, you look at occupational therapy. So I give you an example of if somebody who's had an accident, had a fracture, for example, and has undergone a surgery, but when the person gets discharged from the hospital, comes back home, you normally have somebody from the physiotherapy team come and visit you to help you get back onto your feet and then recover, and they would help you with physiotherapy exercises to help you develop a routine so that you're able to get better and obviously back to your usual way of how you used to work. So wheelchair services, for example, if somebody's had a surgery or undergone a heart surgery, sometimes you would see the local council and the authorities would then come in and deliver. If you are upstairs and there is no way that you can walk, they will provide you a walker. They would also ensure that you have a high-rise chair, some of the other equipment and, let's say furniture type of things, equipments are provided to ensure that you are able to start then functioning normally after you've had the surgery at the hospital. So these would include things like health wheelchair services, looking at health visitors coming to visit you, and they would be all classified as a part of, community health services. Now, one of the other points which I also mentioned that why this unit is important and why we are looking at studying social and welfare provision is because Britain is a welfare state. So when we talk about welfares, what do you mean by welfare? So these welfares include 5 separate categories or group of services. So these include cash benefits, healthcare, education, housing, and personal social care services. Now, if a state or if a country provides these services to its citizen, then it will be safe to say that the country is a welfare state. That means the government looks at providing these basic essential services for people to be able to maintain a healthy well-being, social and well-being, and these services are classed as what are called social and welfare services in a particular country. So when we look at universal tax credit, cash benefits is now basically universal tax credit. You look at healthcare, every individual in the UK has access to healthcare and you don't need to pay for it. You look at education and housing, so schooling, primary and secondary school is free. Even your higher education is free, wherein it is, although through a student finance loan, but the education system is pretty much, funded through the government. You look at housing. So if you are a single parent or if you do not have a roof over your head, then you will be placed into the waiting list with the council, and even housing facilities are provided by the government. You look at other personal social welfare services, things like mental health care. You look at community services which are provided to you to be able to do your daily course. For example, if I have somebody as an elderly who's living on their own and has nobody to look after them, then healthcare visitors go in and obviously provide those, social services. So in such cases, for example, children which are in foster homes or, these are all services which are provided by the government. Now, that is why we look at Britain being a social or a welfare state. Now, I've explained some of these in a bit more detail, but the crux of it is that when we talk about healthcare after the World War II, when the National Health Service was established, the government took a decision that healthcare services would be provided and funded by the government and financed by the taxpayer. And that is where these services would be available virtually free to all people within the UK. So when we talk about the social welfare and related services, these are the five that we would need to mention and refer to, and they include universal tax credit system. So, for example, if you lose your job and you're without a job while you're looking for a job and you need yourself to sustain, you need obviously money and resources to be able to sustain yourself. If you register with the job center, job seekers allowance and other benefits which are covered under the universal tax credit system would be provided, and they would be covered provided as one of the social and welfare benefits that would be available to the citizens of UK or in general within the UK. And these would be classed as, social and welfare services. So medical services, healthcare services, mental health well-being services, education, housing, and any other sort of personal social care services would that you require in order to sustain, live, and maintain a good health and social well-being would be classed as services provided by the government. And what I've done is I've explained them very briefly in terms of how these services, came about when government looked at making or creating policies and initiatives which identified that there were gap areas, and these gap areas, in order for them to be addressed, the government looked at creating these policies which then have gone through the parliament and have become an act, and these have now then become a pretty much standard part of what the citizens of UK can expect in terms of the government coming in and obviously ensuring that these services are available to you and me as citizens of the UK. And when we talk about, for example, setting policies in terms of ensuring that these services are available, to each and every individual within the country without any discrimination. In some cases, the government has also looked at deregulation. They have also looked at privatization, so that some of these services can be provided in private partnerships and more efficiently provided to the members of public. And in such cases, what we do see is that although 95% of these services related to healthcare in the UK are funded by the government, but sometimes we do see private providers also being funded through the NHS to help speed up the provision of these services to the members of public. For example, if I look at a couple of years back, the breast implant scandal which happened, which is involving a French company, wherein some 40,000 women in the UK are affected, wherein the PIP implants need to be removed. And in such cases, there's a waiting list on the NHS, and the NHS is funding, costs for the people or women which are affected to be able to get the surgery done and remove these PIP implants even privately, and the government is paying for it through. When I say the government is paying, the NHS is paying for it, and in some cases, the NHS, if they've under diagnosis, it has been found that it can be fatal, can lead to cancerous growth of tissues, then in those cases, cases are being prioritized, and even funding by the NHS to an extent that people are allowed to take and get these operations and the implants out, even in the US, have been funded by the NHS. So this is where you would see public-private partnership working, because the government is allowing these provision of these services to be made effectively and promptly to members who need it and members of the public who need it. And that is where the private part of it comes in some cases wherein the NHS is subsidizing these costs for the tax through the taxpayer, to be allowing citizens to get the procedures done privately, because it is maybe in some cases going to lead to fatalities, and if the delays happen, then these delays would obviously cause more complications. So what we do get to see is that the government looks at creating favorable policies through which it creates a system which is secure, which is a system which is primarily going to work, for its citizens, and it is in a position wherein it allows the provision of these services to happen seamlessly, so that you and me, people like you and me, individuals, can maintain their social and well-being within the society. Now, one of the things that we need to keep in mind is that these policies, these initiatives, this system which has come into play today did not come into play overnight. So there were lots of different reports. There were lots of different research which was carried out, and this research which was carried out by government setting up committees to table a report, to look at the background and do a comprehensive research in terms of why these facilities were required or why this provision needs to be created, has happened over the years. So there's a bit of a timeline that we need to understand, that how some of these key milestones have been covered, wherein what we get to see in present times today allows the provisioning of social and welfare community services to happen seamlessly, integration, and to happen that and be provided from the National Health Service. So when we look at how this came into being in the 1948, when obviously the basic provisionings of the healthcare services were being done in the UK, it was recognized that community healthcare services are a responsibility of the government, and they need to be delivered through the public health arm of the local authorities. That means hospitals, and at that point in time, whatever the setup was after World War II. Now, in 1962, the government looked at, so we are going through not every year, but the major milestones which have happened over the years. So in 1962, the government hospital emphasized, they paid emphasis on the fact that these services need to be expanded. So Britain had about 40 or 44 different hospitals at that point in time, and the government realized that as the population increase started to happen, and some of these services were required in a local area, it was very difficult for people to travel 20 miles, 30 miles to a hospital to get, let's say, treatments done. And in those cases, the government recognized that we need to expand the infrastructure. And in 1962, some sort of a planning came into shape. In 1963, the health and welfare, highlights or a report was tabled, and this allowed these services to be delivered to members of public by the local authorities. That means within boroughs and counties, councils were getting involved in terms of helping to provide and ensure that these services go to every little part of the country. Their involvement was recognized. Now, one of the first reports, which is the Gillies report that we talk about, is the report which basically, um, tables essentially the emphasis of why the GPs in particular were important in providing this care and diagnosis to the members of public. So the emphasis of the Gillies report essentially was to ensure that surgeries were given adequate responsibilities and empowerment to be able to start participating in helping of the, let's say, diagnosis of some of the illnesses and other bits within the community. Now, when I talk about the Gillies report in particular, it emphasizes that general practitioners or GPs and surgeries can play a very wider role in ensuring that these services are made available to the members of public. So when I talk about Gillies report, there is a particular handout that I would provide. And for those of you who are interested in reading what this report was and how this report was essentially, tabled, and what were the outcomes of this report and how these changed, the policies, the government policies in England, can be looked at. So this particular document was a very significant document because it recognized that the health and social care services cannot be, delivered unless we have the wider involvement of community, which could be pharmacies and GP surgeries and local authorities, so that the services can be provided to every individual where in every corner of the country, and that would also be provided very, very promptly. Now, this report and a further, studies were done, and obviously a further report was constituted, and that was done in the 1965. And that report basically was called the CBOM Community Report. And the CBOM Community, the report essentially, talked about how there could be better coordination between the health and social care services being delivered to the members of public within the UK. So here the key, objectives which the committee or the report actually identified was that they tried to understand that what would be the connection between, or let's say, what would be the main purpose of the community provision if it is to be created within the UK. This would, in what issues would it address, and how these issues would be addressed more effectively rather than being addressed through the GP surgeries or, for example, the hospitals and other larger infrastructure within the city. The report also outlined that in some cases, obviously, when I say outline, I mean by that the key findings of the report was that it concluded that in some cases, without relevant data, evidence, and expert opinion being available, some of these services, would not be, available to the members of public. And in such cases, what it also emphasized on the fact that when we talk about these services being provided, these services needed to be covering not just the adults, but also services related to childcare or children care. And in this case, it divided the services under social and welfare provision into what is called the social service department and other services. So when we talk about personal other services which are provided by the state in terms of welfare services, we look at foster care, we look at social care, we look at social visitors in particular, which are responsible for helping people get to do their daily routines by visiting them, specifically at their place of, dwelling. Then in those cases, these were classified as what are called the other public services or personal services, which were supposed to be provided under this particular provision. Then in 1974, the community health services were transferred to the NHS, and they were done because what the government felt was that under one particular authority, these services would be delivered in a much more coordinated manner to the members of the public. And then what it also did was it classified these services into four different types. And that is what is, explained in this particular flow chart, that when we look at these services, they were divided into community-based services, volunteering role and peer-based services, collaborations and partnerships within the NHS, and then access to these resources which could be taken by all the other organizations to be able to deliver these services to the members of public. So every nook and corner of the country. And this then gave rise to what we see today as the social and welfare community provision and the services which it provides under the NHS to members of public. So this particular timeline is quite detailed. If we go through, say, for example, how these services came into being. And what I've done is this particular data I've taken in from a particular report, which is also available on Moodle, and I'll briefly show that to you. This particular report is called The Origin and Development of Social Care. And obviously the timeline that we look at is quite detailed because it covers, lots of areas in particular. So when we talk about it started in 1948, and then as you can see, it covers some of the major milestones across when some of the changes were introduced, and what we get to see in today's shape and form is what is covered under the social and welfare community provision. So this timeline in terms of the table covers the series of events which have happened from 1948 to what we presently see up until 2006. But I have kind of summarized the major parts of it, which have led to the creation of social and welfare community provision as a whole in the context of this particular unit. Now, the second part of your assignment would be quite useful when you look at this particular table, because it asks you to create a poster or a table showing a timeline of how these services came into being. So that is why this handout in particular is going to be quite important. And for those of you, again, who want to read into a bit more detail, I would suggest that you go through this particular handout, which is labeled as LO1, Learning Outcome 1 handout, which talks about the origins and development of social care in the UK. Now, going back to the presentation, so this timeline is what I've explained very briefly here in detail, and it covers the major aspects of how the origins of social and community welfare provision have happened within the UK. Now, what you also need to look at is that after 2006, what I've done is I've put more detailed steps in, because obviously, if you look at 2006, after that, lots of other changes have happened, and those have been, I've researched those changes, and then those are bits which I've also put up on the slide. Now, after 2006, what you see is when we talk about the Griffiths report of 1998, and after that, the major changes which were happening within the NHS, things like adoption of person-centered approach, the creation of the NHS Constitution, the various acts which were created, the Health and Social Care Act of 2012, you look at the NHS Act of 2010, you look at now the NHS having, provisioning for budgeting for a 5-year period, and, you look at various other organizations which are a part of in a National Health Service and work very closely with the National Health Service to provide these services, whether it's social, mental, and care services. These are all now administered through the NHS. So timeline in terms of major developments and how these things have shaped up when we talk about after 2006 have also been covered in these slides for a basic understanding of what we get to see these services as in present day shape and form. So we are in 2024, but I've covered up until major changes which have happened until 2016. And one of the things which I'll ask you to do is also look at doing a bit of research at your end to see what, if any, changes have happened after 2016 up until 2023 and how they have impacted the delivery of these, say, for example, on the policy side, on the initiative side, and in general, when I say policy, I mean government policy side, and how, or if any act or any new legislation has been introduced after that. But generally, you would see that probably after 2016, no new acts, at least in this, in this context, have been introduced. So the Social Care Act of 2008 was modified to Health and Social Care Act of 2012. You have the NHS Act of 2010, and some of the other acts which come into play when we talk about health and social care, things like Equalities Act, Discrimination Act. We talk about Health and Safety Act, Data Protection Act. Those are general acts which then are used in the context of health and social care, but they are not specifically related to health and social care. So obviously developments have happened, but they are not very, very specific to acts being created specifically within the National Health Service or for the National Health Service, and that's why I've not covered them here. Now, one of the clear reports that you need, there are 3 reports which I would suggest that you need to look at studying in detail when you're studying nursing. One of the first reports is the Roy Griffiths report, which was commissioned in the 1980s. Obviously, it was commissioned, and obviously this report then, came about in 1986. And this report, what was the reason of setting up this report, this inquiry, which was done by the government? What were the outcomes of this particular report, and what did it do is something that you need to understand. So the Griffiths report essentially made a number of recommendations that led to the introduction of what is called journal management within the National Health Service. Now, there was, obviously most of the services were controlled by the Department of Health and were being, delivered through the Department of Health policy decision-making, guidelines, information, anything of that sort. But the Griffith report recognized that in order for the National Health Service to be an autonomous body, it needed to have, what are called powers. It needed to have its own management. And the Griffith report essentially recommended that the National Health Service should introduce what is called a management or a general management in order to drive its operations. And this review, obviously set that the management should play a very critical role in identifying what are the needs and requirements of providing these services, and if there are any gap areas, how they need to be fulfilled. So things like and it also recommended that this management control, when it is created, should also be given greater efficiency and powers to be able to manage their own costs and budget. So budgeting and accountability and costing side of things were made as recommendations that need to be provided to this particular management team, which allows the NHS to then run as a more effective and as a more a coordinated team to be able to make its own decisions, take decisions on its budgeting, and obviously controlling costs to be able to decide which places where the budgets of the NHS is going to be utilized in order to ensure the best possible services are provided to the members of public. Now, this report is also going to be something which is a handout that I'm going to provide as a PDF, which is available, and you should go through this particular report, and that report would essentially help you understand, why these changes were introduced and why the government actually constituted this particular report way back in 1986, and the report was published in 1988, which made recommendations as a third party and suggested to the government that these are the changes that need to be essentially done in order to ensure that community care is brought to the forefront within the NHS in order to provide services to the members of public. So this particular bit was quite important. And when we do talk about community care, that is where this report becomes useful. And that's the reason why I'm suggesting that if you look at studying this report in a bit of more detail, this would allow you to understand that why community care as an agenda was brought forward by the Griffith report, and why did it recommend that the NHS and the management, when there should be creation of management within the NHS, and that should be given powers to essentially allow it to make decisions with regards to budgeting, costing, and that would allow it to have a wider control in terms of how these services can be effectively utilized and provided to the members of public. Now, the second report that you need to look at understanding and having a very good understanding of is what is called the Marmot Review. Now, when we talk about the Marmot Review essentially, what was the purpose of it? That is the first thing that you need to look at. Now, after the government has identified that there are bits and pieces that are missing links in the health and social care provision within the country, when it looks at services being provided by the NHS, what it did was it set up a committee to essentially provide a comprehensive report in terms of healthcare inequalities. That means, why do we see certain areas in the country receiving less budget or having more fatalities, or in some cases not having the infrastructure developed as quickly as possible in terms of keeping up to the requirements of how the city and the requirements within the from that local areas is growing. Now, the purpose of this review was to look into the differences in health and well-being between social groups. So, for example, people which have immigrated to Britain, we look at people which basically have access to better resources within the society in terms of education or benefits. Then was there a link between health and well-being and these social groupings and the benefits that they get? And if there were links between them, then how does the government and the NHS look at reducing these inequalities, which would allow individuals to get pretty much equal facilities equal facilities in terms of treatment when we talk about the National Health Service. So the Griffith report actually looked at understanding and putting a perspective in front of the government to describe what is the importance of what is the relationship, let's put it this way, between social and social benefits or social and welfare benefits and health and well-being. It looked at identifying what are the inequalities which result out of these social and welfare benefits not being provided to members of public or being provided disproportionately. So it looked into creating what is called a social inequality matrix, which basically the government needed to address, and it identified that where the problems are, and these problems could be because of education, because of employment, because of income, because of the quality of life the individual enjoys in a particular neighborhood. And these social inequalities that we get to see is what the Marmot review actually, ended up, prescribing or ended up basically talking about. And when we talk about the social determinants of health and well-being, this is what this particular report started to develop. So the picture that I brought onto the slide basically talks about the social determinants of health and well-being. And what were these social determinants is what something which the Marmot review actually emphasized or paid emphasis on. So it helped discover that because of these social inequalities, which actually stem from employment, income, quality of life that you enjoy while living within a particular area, and your educational background, then differentiates the kind of services that you can get, and that is why it provides different outcomes to people which come from different economic backgrounds, and these inequalities need to be addressed within the NHS when these services are provided. So this particular review, which was carried out by, it is called the Marmot Review, which was carried out and published carried out in 2008 and then published in 2010, led to the creation of what is called the Health and Social Care Act, or amendments to the Social Act of 2008, and it led to the creation of what is called the Health and Social Care Act of 2012, which aimed at improving health outcomes and reducing inequalities when it comes to the services being provided to the members of public. So a very important report. And this particular report, I would suggest, again, there's a PDF or a handout which I've provided. And this particular PDF and a handout, basically discusses, why this review was very important, what was the outcome of this review, and then the conclusions of what the government needs to look at making changes in terms of policies, have been published in this report. Now, for some of you, this is quite a big document, and these two reports, which I'm referring to, the Griffiths report and the Marmot review, is something that I would suggest that you need to look at reading, although they are, about 200 pages for one of them, and I'll show you that very quickly. But they are going to be useful for you to understand how some of these changes which have led to the creation of the management structure within the NHS, and how it helps further the let's say the bridging of inequalities when social and welfare services are delivered to the members of public are addressed. So these reports are quite important because they show what is called the origins of how social and welfare community provision was brought in, because it allowed deregulation, it allowed more autonomy to local communities and councils to be able to help decide budgeting and how these services are going to be delivered to the members of public. So in general, this particular these reports or reviews which were carried out essentially allowed the government to make vital changes in the let's say provisioning of the national health service, which includes both social, mental care and healthcare services and well-being services to be carried out, and then how they have become quite, let's put it this way, they've become more effective and more streamlined, and there is accountability The objectives are very clear. It allows accountability to be established, the budgeting to be done, and then obviously it allows the NHS management to create strategies for 5-year, 10-year, 15-year planning, which basically looks into how these changes would need to be preempted and then implemented even before these situations or timelines are essentially, reached. And then the role of private sector, the role of civil service in some of these provisioning of these services, creation of these guidelines, and how it impacts and helps in the development of policy, and then the adaptation and implementation of these policy at the local level by the local council is essentially done. So let me just very briefly show you the report, which is a PDF document that is going to be available. And this is the Marvet review, which you see. Now, some part of this could be skimming through this particular report because this is a report published in the Parliament UK website from which I've downloaded. Obviously, there are a couple of pages that you can skip, but the basic bits that you would need to look at would be, talking about the executive summary in general, which talks about giving you an overview of why this review was established in the first purpose. So a couple of pages, including the first chapter, is what I would suggest that if you read in thorough detail, would allow you to get a grip on why this report was very important or why this review which was carried out became very important. Now, in addition to that, the Griffith report, if I mention, is a series of reports. It's not just one report; it's a series of reports that need to be looked into. Again, for the purposes of understanding why this review was put into place by the government, and then how did it bring about some of the essential changes that we see in NHS from a point of view of provisioning of some of these health and social care services which are delivered through community and social welfare provision. That means essentially local authorities, councils, and the members of the community within a community. Say, for example, we talk about community healthcare centers, district nursing, and how these came into being is something which is because of the Griffiths report. So taking you back to the presentation, just very briefly. So some of these reports then looked at instituting changes, and these changes essentially then allowed, the community services to essentially start happening or being provisioned. That means basically budgeting was allowed to be done at the local level, and what was the best possible route to provide these services to you and me as individuals within the society was then decided by the local authorities. And the video that we saw earlier, which was Public Health England, explained that why this role was brought into, why communities were essentially brought into the delivery of these services, because one such aspect is that I know my neighbors, I know most of the people wherein I live, and if these services have to be provided, then it allows the individuals to be aware of what type of services are required, which place you live in, what are your, they are basically aware of you as an individual because they are a part of that same society or the community where you live, and that would allow these services to be delivered much more effectively. So why do you register? The question is, a simple example that I would give is that if I'm living in, say, Didsbury, I would need to register with a surgery in Didsbury. I wouldn't probably register with a surgery in Wally Range or, Charlton or someplace else. So you would go to your local area and the GP surgery would be able to provide these services. When you look at medicine, or if you look at buying any medicines or prescriptions being given, they will be given to you by the local pharmacy in that particular area, who would know and maintain your patient record, your history, and your, and obviously would be able to better service you rather than you getting medicines directly from the government or from a different place or going to see somebody in a different location. So that's why when you look at the setting up of the primary care trust, the hospitals. So, for example, people would generally in a particular area go to a particular hospital. There are 5 or 6 big general hospitals, obviously in Manchester and Greater Manchester area. So you look at the Manchester Infirmary Infirmary, you look at the Greater Northern General Hospital, you look at Wythenshawe, you look at Bury, you look at Bolton. Obviously, in other areas in the Greater Manchester Borough, you'd have other hospitals, and the members of public would essentially be looking at going to the local, hospital, because this would be more easier. It would be, more easier for them to access that service. And obviously, you wouldn't need to travel, miles. When we go back to 1960s, when the government recognized that we need to expand the infrastructure, is because people were looking at traveling distances to be able to get that, service from the National Health Service, or basically basic services if it was required. Now, when we talk about, in general, some of the, let's say, some of the contemporary issues that we look at within health and social care. One of the current issues that we talk about in terms of contemporary issues in health and social care is currently the aging population in developed countries. And this, means that the government needs to spend more in terms of, national health services. So the budget, if you look at, 1/6 or 1/7 of the UK government budget is actually spent on the National Health Service. And this is because the government needs to cater to individuals as in the population, because the country is now having an aging population. So there would be additional cost, additional infrastructure required to be able to provide these services, because the population is getting old. So when we look at these ongoing issues, when I say ongoing issues, what I mean by them is evolving healthcare needs that are coming across with the aging population. Means that, say, for example, because of globalization, modernization, the problems or pandemics of, obesity, for example, or diabetes or heart disease, and for example, those are conditions which are growing in the population today, and that is where the budgeting side of things and the infrastructure side of things have to be, appropriated by the National Health Service to ensure that they are able to provide these services when members of public need it. So in such cases, the budgets, and the kind of spend in the budgets which is being done on, some certain modern disorders and diseases like obesity, diabetes, cancer. You look at some of the other treatments which are required to be done, and that is where some of, when we talk about ongoing issues and evolving issues, which is what the National Health Service is grappling with, is what we will term as contemporary issues in healthcare. And these are all because of aging population, our changing lifestyles. This is also because of, how modernization and globalization is happening in the country, and in some cases it is driving your lifestyle preferences, and they are leading to different types of illnesses or diseases. And that is what the NHS needs to that is why the NHS needs to modernize, and obviously ensure that it has the relevant equipment, expertise, people, manpower, and the infrastructure to be able to deliver and cater to these services as and when the need arises. So some of the top line facts that we look at in terms of big issues, that if you were to identify and ask yourself, would be, how does the government look at, say, for example, waiting times? Now, one of the key things which some of you would have noticed, which are covered time and again in the news, is the waiting times for A&E services, or ambulance and emergency services. Now, sometimes you would see that this, in terms of national figure, has been defined by the government as 2 hours. But in most areas within England and Wales, the waiting time tends to be in excess of 2 hours, 44 minutes, or 3 hours, even 4 hours in certain areas. So while you're picked up by the ambulance team and taken to the hospital, you're still within the ambulance and still waiting to be discharged to a relevant medical team within the hospital before the ambulance can be freed to take further calls or inquiries within that area. And those wait times have to be reduced as per the government target and the NHS target of 2 hours maximum. But they are being stretched because the requirements are increasing, simply because of the rise in the population, and obviously the services being sparsely populated in order to meet the requirements of the population in that area. So in this case, the NHS management is obviously in discussions with the government and the Department of Health to say that, we are stretched for resources, we are stretched for budgets. And in this case, this is the only, these are bits which need to be modified or looked at in order to ensure that we still are able to maintain the target set by the Department of Health or the NHS in terms of management, to say the waiting time needs to be less than 2 hours or less than 2 hours. So there are lots of these top line big issues which the NHS and the management within the NHS and the government is trying to work with. And they tend to be what are called ongoing issues or contemporary issues in health and social care. So, with this, I hope you understand the basics of it in terms of why social and community welfare provision is becoming important and more important within the National Health Service, and how the National Health Service now provides these services to, with the help of local communities, local authorities, councils, and community welfare centers and pharmacies to individuals within a particular area. Is that okay? Any questions on this? Any thoughts? Any questions? Okay. Now, let's look at some of the assessment criteria. Now, with this background that we have covered in terms of what is social and welfare community provision, what are the key reports which have shaped up this particular provision and the importance of this, let's look into some of the criterias for this particular learning outcome. Now, the first one talks about explain key social issues which we need to talk about from a contemporary issues within the society which are impacting healthcare and healthcare delivery of these healthcare services to the members of public or within our community. So the first one we talk about is healthcare inequalities. We talk about mental health, aging population. We look at obesity, social isolation, and these are some of the issues which are the big issues which the NHS is trying to tackle with the help of delivery of these services by involving members of public, which is basically the community, and these members of public providing the services to other members of public within a particular area. And that is what we need to understand when we talk about social issues which are important from a societal perspective. So these issues, why are these issues? Any idea? Why do you think these are issues or termed as issues, and why they need to be tackled? Any idea? Okay, no worries. So when I talk about, basically detailing of that, why are these contemporary issues, or why are these issues which are, so let's look at first the definition of contemporary. For those of you, when we talk about, issues and we talk about contemporary issues, contemporary means these are living or occurring in the same time, or they are all happening in the times in which we are living. They are not issues of the past. They're not issues that we're going to face in the future. These are issues which are ongoing issues. So when we talk about contemporary, we talk about issues which are happening in the present time. And that is where when we talk about the word and literal meaning of contemporary. So, and when we say contemporary issues, these are factors or these are problems which are currently affecting people and they are unresolved. There are no long terms, there are no, let's put it this way, short term solutions to these issues. These issues would need to be addressed through policies, by initiatives taken by the government in order to create new policies or legislation which will allow them to be tackled. So these are issues which are currently affecting population, or issues which are affecting a population within a geographic area, and they are issues of concern. They can cause big problems. There is a lot of debate happening on it, and some of these issues could be controversial because spending money budget on some of these things without having to get desired results or outcome might be controversial, because it would be seen as government wasting taxpayers' money. And in some cases, these issues, cannot be tackled in short term. They are long term issues. They are issues that we are living with. That is why we need to talk about these as contemporary issues. Now, what are these issues when we talk about issues in today's society? So, one of the big issues that we talk about is healthcare inequality, access to healthcare. You know, if I have more money and say, for example, I'm suffering with cancer, I might be able to, with the NHS, I might be put onto a waiting list to receive treatment like chemotherapy or medication. But if I have access to money and if I'm well off and my income levels allow me to get private healthcare, then in those cases, some individuals who have access to private healthcare because of the economic background would be able to get, say, for example, start immediate chemotherapy or start getting immediate treatment, which would increase the longevity of their life, or, for example, decrease any sort of fatality, or give them access to healthcare facilities, which in this case might not be available to individuals which are not able to afford it, and that would be termed as, say, inequality. So when we talk about inequality, we are talking about things which are going to be related to say, for example, income, socioeconomic status. We are going to be looking at race and ethnicity. We are going to be looking at what is the background in terms of education. Where do you live? Where do you come from? So, if you're living in a more affluent area, or if you're living in a more commercially, let's say, expensive area, some of the infrastructure in that location might be much better than some of the other areas in the city, and this would create what is called health inequality. So when we talk about Burnley, for example, when we talk about certain boroughs or counties within the UK, within England and Wales, what we do get to see is they are called deprived areas. Now, in this case, what we have seen is, or in some areas, if you look at within Manchester, within Shaw, when it was established, it was the largest council estate in Europe after World War II. So people coming from within Shaw or living within Shaw, had access to certain facilities, and this was, typecast as a development wherein people uh, you know, um, were rough sleepers, or basically, essentially not having the same access to facilities as in other areas within Manchester. Now, this is a inequality, because what it basically evidences is that there is a pattern which we get to see when people do not get equal services because they come from a particular neighborhood, they are not having access to healthy food or safe environment. And in some cases, this can then contribute to healthcare inequality. That means their life expectancy, their overall well-being, their their ability of their body to fight illnesses, or other such, say, for example, diseases, might be decreased or lessened because they're coming from a less affluent area, and this is primarily because they do not have access to, say, healthy food, safe environment, or healthcare facilities, and that would be termed as a healthcare inequality. Is that okay? Is that understood? So in some cases, when we look at taking a wider example, is that when we talk about developing countries in the Southeast Asian region, or in Africa, or in other places, for example, when we talk about um, countries in the Far East, you generally see that access to healthcare is limited. Hospitals are there in major cities, but people living in villages or smaller towns do not have access to those facilities. And in those cases, their ability to be able to tide over a particular illness, or come out favorably because of an illness that they've, or a disease they've contracted, is far lower as compared to people living within developed cities or bigger cities, wherein the access to infrastructure, hospitals, modern healthcare, and medicine is easily available. And in those cases, it causes healthcare inequality. So people within smaller towns and villages, or people which are living far off from cities where the infrastructure is developed, face this inequality because they are in a background wherein the access to some of these facilities is restricted or not available. And because this is restricted, if they were to face an adverse event, or a adverse climatic event, of floods, or, for example, drought, the resources from or the resources in those cities would be limited, and that would mean that people would have less chances of survival, and that would be termed as inequality, because the government is not able to maintain infrastructure and provide that across the various cities, towns, and villages. In those cases, this would create what is called a health inequality. Then we look at other points like mental health, we look at aging population, we look at obesity, and we look at social isolation. So, for example, sometimes when people feel, if you look at an elderly couple and one of them has passed away, the other person becomes lonely. And in such cases, if they do not have friends and family taking care of that person when the other person's partner has passed away, then the person can go into isolation. And in those cases, not getting support from the near dear ones, family members, or from the wider community, which could be friends, I would say the friends and family circle of the individual, then in those cases, you would generally feel that the person would become isolated. And this isolation would lead to loneliness, would lead to depression. And in some cases, this depression can also have negative impact on the person's physical health. And that would mean that the council, the local authorities, and the wider community, which is people, neighbors, friends, family members in and around that area, would need to come in and provide help or help out in the in the basic facilities or functions which the person needs to do in order to survive. So this would be termed as social isolation. People who are living in the far off islands in Hebrides or in Shetlands, there is constant fear of social isolation, because in adverse weathers or climatic events, the communities tend to be cut off, and in those cases resources and other basic facilities take time to reach them. So in those cases, these communities have become self-sufficient, but because they live in isolation, they have not they do not have um, um, how do I put this, they do not have access to wider let's say facilities which are available in towns and cities closer or within the mainland UK. Then in those cases, sometimes the government has to look at compensating or in some cases help in relocation of these communities to mainland UK. One such example that I would give you is, for example, if you look at a school, and in Shetlands and some of the islands, the school has maybe 15, 20, 30, 40 children only. Now, if you look at social isolation as a problem, what we generally get to see is that in those communities, because there's restricted access and some of the development of social qualities does not happen. So in some cases, what the government does is then encourage people to come to the mainland UK, because some of these facilities, which are basic facilities, are not available and are required for individuals or children to grow and develop. So in some cases, that could be a wider problem in bigger countries or cities wherein the population is sparse and the country is huge, or resources are quite widely spread, but they are at distances, and in some cases, if people live alone, or obviously when we look at certain locations like Alaska, or in bigger countries wherein there's a considerable amount of distances among cities and towns, then that can lead to social isolation. And in those cases, social isolation can lead to mental health care illnesses or mental health illnesses, and mental health and well-being in general tends to be affected. So these are issues that we need to look at covering when we talk about contemporary issues that can impact health and social care of a particular individual. Now, any questions on the first assessment criteria? Any questions? Okay, let's briefly look at the second assessment criteria, which is talking about discuss how these issues can affect health and well-being. Now, the same issues that we've discussed in first assessment criteria, which are issues of health inequalities, mental health, aging population. What I would suggest is, because it talks about explain, we need to look at any one of this issue and then explain how this is going to affect health and well-being of an individual. So in this case, if you pick out, say, one particular issue, which could be, say, an issue that arises because of health inequalities, if I put it this way. Now, if I talk about health inequalities, health inequalities, that would be any sort of unfair and avoidable differences in health that are present across the population in an area and within different groups within the society. So these could be in terms of how people live, what kind of healthcare conditions they may experience, and what care is then provided to them in a particular area. And when we talk about these conditions, they can be, changing conditions because where we are born, where we live, how we work, and at what are the various facilities available in that area for us to be able to getting those services can impact, and have an inequality. That means this can be disproportionately affecting the individual. And when we talk about health inequalities, we would be basically looking at the availability of these services in a local area. For example, the opening hours, the access to transport system, access to childcare, look at literacy in terms of how educated you are or what are the facilities that you have in that area to go to a college, go to a good school or a university. And if you and is there some sort of intimidation or fear within that area? That means when we look at certain cultures, in some cases women only go to doctors accompanied by their partners. So in such cases, sometimes discussing problems openly with the doctor, there is a fear in the minds of the ladies or females, because they wouldn't want to discuss this without their partner being present. So in such cases, fear can also be an intimidation, and that could also deprive the individual from getting the proper care which is required to overcome a particular disease or, for example, an illness. So when we talk about health inequalities, we can talk about people living in high deprivation areas, which could be coming, say, for example, from the BAME community, Black, Asian, minority, ethnic community. And these ethnic communities, have a very different approach to looking at how some of these things are discussed openly. And in those cases, the community part of it, the cohesion or the cooperation from the community part of it becomes very important, because in some cases these communities are not open to discussing problems openly outside with doctors or GPs until unless they have some sort of confidant or a partner accompanying them. And in such cases you would generally see the risk of these communities experiencing inequalities increases. That means they would have a range of healthcare problems which could be chronic problems, and in some cases they are not diagnosed or they do not get discussed until unless it comes to a particular stage or a stage wherein these become chronic, or the medication, or sometimes people start doing home medication. They say, oh no, this is a small thing, you should be able to manage yourself, and that is how it is looked at within these ethnic communities. And when it comes to a stage wherein it is no longer treatable or manageable within, and then they seek help, and it sometimes becomes too late. And in such cases, it can also lead to fatalities. And this is what the health inequalities tend to be. So the councils, the local bodies do what is called leafleting, providing a lot of information, looking at asking people to participate in surveys. And this is where they're trying to get hold of these, understand by getting hold of this information that where these inequalities could be present and how they would go about addressing them by taking the help of social workers in that area or people in that area who are a part of that society or that community, to be able to give them understanding and background in terms of what is required to work with them, what are the cultural backgrounds and nuances, and how they would be more useful by understanding the culture and the background the person comes from, and then using that as a pretext to deal with that inequality and ensure that the person gets the required services when it comes to healthcare. So any one example you could discuss or pick out from any of these that you can relate to, and that would help you cover and understand this particular task, which is discuss how issues affect health and social well-being. Now, There are one or two good sites that I would give examples of, and I will put it onto Moodle. One such particular area on the NHS website, which I've put across, for further reading, which is given here, is what I would suggest that you need to look at. And let me just very briefly show it to you. That would be useful for you to, look into and read. So, what are healthcare inequalities? This is one point that you could pick out and discuss. And this is given across, in 3 or 4 sections. There are some bits that you can click on, and it'll open up relevant reports, which would give you some idea in terms of how these inequalities are addressed. If provided you talk about health inequalities. If you talk about mental health, or if you talk about obesity, you talk about, say, for example, isolation, aging population, then you would need to look at different reports, which would be, obviously looking at some of the points which are given here. And this would be a good read for you to be understanding this task in a bit more detail. And that would, at a later stage, also help you, if you've read it, to do your assignment when we have completed the unit. So I would put some of these links onto Moodle that you would be able to also see, and the reports that I mentioned, and they would be helping you to further understand what we've discussed as today in terms of today's learning outcome, which is learning outcome 1. So let me briefly switch you over to Moodle and show where they are available so that you're able to access it after this particular lecture. Let me put this across. And so on the Moodle, this is the unit, which is unit 11 that we are currently studying. So in terms of the handout, which I would suggest that you need to look at, the basic handout on this is a presentation that we are covering today. And then this is a particular handout which I want to show you that you should be looking at referring, which is called the Learning 1 handout. It's a Word document you will be able to download. I've downloaded that and I'll show you that in a second. And then I put the Griffiths report here, and then example of healthcare inequalities, which I'm going to move up to Learning Outcome 1 presentation, so that these are related to Learning Outcome 1. And the table that I was talking about is this table, which essentially I've shown you earlier, from which I've taken, the key milestones, things like the Griffith report, the Marmot review, and how they've helped shape social and welfare community provision. Now, one particular handout which is there, which I would want you to read on Moodle, and this will download to your local machine, is this one, which talks about welfare provision for community care and health care work. So this covers the basic aspects of it in terms of the theoretical background, that when we look at healthcare approaches, what are the various approaches which have come about, in various countries, and what did Britain adopt? So we adopted, we basically adopted to keep the National Health Service as a state-run service, which was initially, after the World War II, the Beveridge Report essentially constituted that, and then it put out a framework of how the National Health Service is to be created, in the UK, and that talks about the National Health Service and how it came about, with some of the main timelines, and the development of various acts that were introduced over the years. And this would be covering, for example, Roy Griffith's report, the Marmot review. There is one other report that you would also need to look at, which basically we'll cover in Learning Outcome 2. So there will be some mentions of that report here as well. And these reports are the 3 main reports, the Lord Darzai report, as I would put it this way. So 4 reports in general is what I would suggest that you should be aware of, when we talk about the National Health Service. These are the 4 reports. The Beveridge Report of 1942, finalized in 1948, led to the creation of NHS. The Griffiths Review, Lord Darzai's report, which led to the creation of the NHS Act, and the Marmot Review, which led to the provisioning of these services to be delivered from community and local authorities, empowering them to take decisions on budgeting, decision making, and obviously how these services are to be delivered to you and me as somebody who lives in the UK was done under the Marmot review. So these are the 4 reports that I would suggest that you should be looking at reading and should be aware of. This particular handout that you see here would provide you, all the details that are required to get some benefits of the first learning outcome in this particular unit and why it is important. So a fair bit of reading that you guys have to do, and I would suggest that you need to do this so that you are clear in terms of when we talk about this word social and community welfare provision, you are clear in terms of how this came about, why is it important, how this is put into practice, and what's the use, and how this is delivered to the members of public as far as the first learning outcome is concerned. So I hope this session has been useful. If you have any questions, please feel free to ask me, and we will otherwise meet up tomorrow to discuss learning outcome 2. Any questions?
No questions. No questions.
Okay, that's great. So we'll see you tomorrow at the same time at 10 a.m. to discuss, learning outcome 2. And if you think of any questions till then, feel free to write them down, and then we'll just take them up before we start the discussion on our next learning outcome. So take
All right.
care. Thanks for attending.
Thank you.
And bye
Thank
for now.
you.
Bye.
Bye.
Thank you.